We have continued our PG medical education and continuing with the third season, we are trying to cover all the basic topics and important clinical scenarios. So, in the same line, today we have a topic of neuroophthalmology, different strokes of disc edema. This is basically various clinical scenarios of the optic disc edema, how to go about it, how to investigate and treat it. And to teach that and to discuss with us, we have none other than Dr. SUSHA with us. Ma'am has done her pediatric and the neuroopthal fellowship from the LV Prasad Eye Institute, and at presently she is practicing in Mumbai and Thane. Very warm welcome, ma'am, and thank you for giving us time for providing your presentation and the lecture on the BOA platform. On the BOA platform is slowly converting into international. Like as you can see, we have a lot of Russian delegates attending. The medical colleges also Russia also are getting connected with us, and plus Mumbai colleges and Maharashtra colleges are always there. So I will not waste much more time. You can start sharing the screen, ma'am, and you let me know when we want to do the polls. We will do the polls accordingly.
Yeah. Okay. First, I'll start sharing my screen. Started sharing, right?
Yes, you can make it full screen, ma'am.
Yeah. Visible to everyone? Hello?
Yes, it is visible.
Yeah. Yeah. Okay. Without further ado, I'll start with the topic. A very good evening to all my lovely audience. A special thank you to Bombay Ophthalmic Association and Dr. Swapnesh Samant for honoring me with being a presenter in this series. A special thank you to Sumit for diligently organizing and coordinating with me. And a special mention to all my mentors and teachers and students who over the years have helped me develop my skill in neuroophthalmology and pediatric ophthalmology. Uh, Different strokes of disc edema. Actually, disc edema is a very, very big topic, and in an hour to cover all of them and do justice to all of them might be difficult. I have tried my level best, and if there are still doubts or if you want me to elaborate on some of the topics, probably we can coordinate and have a lecture in the future as well. So to start with, I have put in a lot of representative photos since this is a PG teaching class, so that you all can better understand what is the difference between the different types of disc edema. So this is how the schematics of the whole thing is going to be. We have to understand the terminology, what is disc edema, the mechanism behind it. We have to note the signs, identify the lesion, advise the right investigation, interpret, and reach at the right diagnosis. I will be giving a few pointers to treatment, though this is not going to be a full textbook class. And I will also be showing you a few case scenarios. So we will start with the case scenarios. Sumit, I am starting with my case one. Once this is I explain the scenario to the audience, you can start with the poll.
Okay.
So there is going to be a poll for this case, and there is a 32-year-old obese female who presented with the OPD with complaints of transient obscuration of vision in the morning when she gets up from bed, which gradually becomes better throughout a few hours. It is associated with headache. On examination, she had a vision of 6/6 in both eyes. The color vision was absolutely normal. Movements were normal. Confrontation seemed to be within normal limits. And the anterior segment also seemed to be within normal limits. If you see the fundus, you can see that there is disc edema, more in the right than in the left. So, Sumit, you can start the poll.
Yes, ma'am. Just a second. So all of you will get the options to all of you will get the option to press either A, B, C, D out of your Zoom platform. You need to use that and press either A, B, C, D. I'm just launching the poll. These are the four options. You can start answering. So option A is visual field. Second is fundus fluorescent angiography. Third is neuroimaging, and fourth is carotid Doppler. We'll wait for 45 seconds to 1 minute. I hope everyone can answer. We can't see who answered what, so don't worry. You can answer
Hmm.
what. Come on, come on. Only 17, only 38% people have answered. You just have to answer A, B, C, D. You have to go in a polling. You can see the poll, and you just have to press either A, B, C, D. I will wait for 10 more seconds, and then we'll stop the poll. Okay, fine. I'm only 50% have voted, but I think we'll go ahead, and we have other questions also to come.
Yeah, yeah. So the four options were visual fields, FFA, neuroimaging, and carotid Doppler. I will be going by the questions first, then we'll be having our talk, and then at the end, I will be revealing the answers to all of these. And by the end, you can see if there has been a change in the thinking process, whether you feel that it could have been a different answer. So our case number 2 is of a 50-year-old male who presented to the OPD with a painless gradual blurring of vision. His vision is 6/9 in both eyes due to an early cataract. Fundus showed a bilateral disc edema. Now the doubt comes whether the 6/9 is because of the disc edema. Now the perimetry shows a mildly enlarged blind spot, and an MRI with brain with an MR venography was done, which was within normal limits. And the lumbar puncture had showed normal readings as well. The clue is that his wife complains of a whooshing sound when he's sleeping beside her. What next? What investigation do we do next? What do you think it is? So, launching the options. Over to you, Sumit.
Yes. So these are the options, and I think your polling time starts now. Please start answering. The option is carotid Doppler, second MRI angiography, third sleep studies, third is ENT opinion for the partner. Come on, the rest also can answer. Please be quick. Why rest are not answering? Everyone can answer. More you participate, more you are going to gain out of the lecture. This is only for all of you.
Is the polling done?
Just a minute, why not stop? Yeah, we'll stop now. Yes, done.
Okay, so for the previous question, the options were whether you should go ahead and do a carotid Doppler. Do you think this is a CCF? Should you do an MR angiography, some sleep studies, or ENT opinion for the wife, since she's the one who's hearing the whooshing sound?
Ma'am, you can make it full screen, please.
Yeah. Okay, our third case, a 12-year-old boy with severe throbbing headache and sudden onset diplopia. Vision in the left eye and the right eye 6/6. 15 degree of esotropia on Hirschberg's with a restriction of -1 on abduction in both the eyes. The child has a mild anisocoria which was undetected on the previous visits due to a dilated examination being done every time and the surgeon being seeing the patient with dilated pupils. Both eyes fundus showed disc edema. There was no history of fever, eye pain, or any other medications. My clue is that he looked abnormally tall for his age with a rather prominent jaw. Does that ring a bell? So, what do you think is the diagnosis? Over to you, Sumit.
Yes. So this is the last poll. You can already see the options. I will just launch it so you can answer. Please start answering. 20 seconds more. 5 seconds more. IIH is idiopathic intracranial hypertension. Okay. Time done. Ma'am, poll is stop.
Okay. So our options were, is it idiopathic intracranial hypertension? Is it an AD's pupil? Is that why there is an asymmetry? Uh, is it something as severe as an optic nerve glioma? Or could there be an intracranial tumor? So while you ponder upon these, let us start with the terminologies. Disc edema. What is disc edema? It is elevation of the optic nerve head due to causes other than raised intracranial tension. So here is what I would want you to focus on. There is a difference between disc edema and papilledema. Every disc edema is not papilledema. So what is papilledema? Papilledema is elevation of the optic nerve head associated with and caused by raised intracranial tension due to axoplasmic stasis. Pseudopapilledema, this is also one more entity which confuses a lot of us when the patient comes to the OPD and you have an accidental finding of papilledema. So whether it's a true disc edema or is it a pseudopapilledema, the appearance of an elevated optic nerve head without actual swelling of the nerve fiber layer is called as pseudopapilledema. What are the causes of disc edema? Disc edema can be unilateral or bilateral. So we have papillitis, papillophlebitis, AION, that is anterior ischemic optic neuropathy, central retinal vein occlusion, orbital tumors, ocular hypotony, and Foster-Kennedy syndrome, which can present as unilateral disc edema. Bilateral disc edemas may be papilledema, hypertensive retinopathy, as in malignant hypertension, diabetic papillopathy, thyroid eye disease, keratoconus fistulas, Leber's hereditary optic neuropathy, anemia with some hypoxemia can also present with massive disc edema with rot spots and hemorrhages, and cavernous sinus thrombosis, to name a few. So what is the difference between true disc edema and pseudodisc edema? Once you start your clinical practice, you'll realize that there are many more differences. But as of now, I'll start with the disc color. In a true disc edema is generally hyperemic, unless it is an AION, which can present with a sectoral disc pallor. Pseudodisc edema is yellow in color. Nerve fiber layer is opacified. In a case of true disc edema and pseudodisc edema, it's transparent. Large vessels are normal. And in cases of pseudodisc edema, generally you see on the surface of the disc there are anomalous trifurcations of the major branches of the vessels. They may look spoke-like, as in a morning glory disc. Spontaneous venous pulsation is absent in true disc edema, and it is present in 80% of pseudodisc edema. That means in the normal population also 20% may not have spontaneous venous pulsation visible. Hyaline bodies are absent in true disc edema, and they may be present in pseudodisc edema. Optic cup is normally initially filled unless it's a disc at risk in NAION, or it is small or absent, as in a pseudodisc edema. Nerve fiber layer hemorrhages are frequently present in true disc edema, and in pseudodisc edema they are absent. FFA will show dry leakage at disc in true disc edema, whereas there will not be any active leakage. There may be a late staining in cases of pseudodisc edema. Now, what is the difference between papilledema and papillitis? That is, in a case of disc edema, where the optic nerve head appears swollen, versus papilledema. So, the laterality, papilledema is generally bilateral, but it can also present as unilateral with consequent following of the otheritis. Papillitis also is generally unilateral, but can be present bilaterally. When pallor sets in one eye, NAION can start in the other eye as well. Vision-wise, papilledema will generally have a transient loss of vision. There will not be complete loss of vision. Many a times when these patients present to our OPD, they might have full vision, 6/6 central vision. And in papillitis, there is a sudden loss of vision. Ocular movements are generally normal in papilledema, except if there is a sixth nerve palsy. And they are generally restricted and painful in papillitis. May not be in all cases, but yeah, in neuritis, especially optic neuritis, you might have painful movements. Color vision is normal in papilledema. It's affected in papillitis because there is active inflammation of the nerve. Pupillary reaction is normal in papilledema. Papillitis may present with a relative afferent pupillary defect. Vitreous opacities are absent in papilledema. Papillitis, they might be present. They may be present, not in all cases, they may be present. Disc swelling more than +3 diopters in papilledema, whereas it is not as massive. It may be +2 to +3 diopters. Again, this is a relative term because I have seen cases with neuroretinitis with actual disc swelling, which is up to 3 diopters. Hemorrhages and exudations are more in papilledema as compared to papillitis. Visual field is constricted. There is an enlarged blind spot in papilledema. In papillitis, it's generally a central or centrocecal scotoma. The recovery of vision, unless you treat it really early with a mild papilledema, the recovery of vision is usually not complete if optic atrophy, secondary optic atrophy sets in a case of papilledema. If it's papillitis, that is, if it's a retropulbar or optic neuritis, generally after 6 weeks or so, the vision recovery is complete, unless it is an atypical case of optic neuritis. So the diagnosis is best done by stereoscopic viewing of the disc with a high convex lens with magnification, especially to detect subtle changes in the disc elevation. History of thalmoscopic findings and then tests like vision, color vision, fields, etc. can give us a clue as to what is the condition we are looking at. We shall come to these details later. I would like to stress now, and again at the end of the talk, I will be stressing on the point that the absolute necessity to get a perfect diagnosis is to take the history, probe the patient about when it started, how it started, whether episodes have been frequent, whether they have come before. Our basic history taking along with history of similar issues in the family, the changes in their normal habits, their sleep patterns, history of snoring. All these things are very, very crucial in arriving at right diagnosis and avoiding costly investigations to the patients, especially, and for a good referral. So what are the causes of papilledema? I will not be enumerating everything. Everything is there on the screen. And I would also request you all not to waste your time writing it down or taking screenshots, because I will be giving a PDF of the entire topic to Dr. Sumit, and he can give it to you all pass it on by email or something. So the causes of papilledema, you can have ocular causes as well. So I have seen patients, most of us have come across patients with ocular hypertony. Hypotension, the decreased pressure in the prelaminar region will lead to disc edema. We will come to the mechanism of how actually the disc edema sets in the next few slides. Acute hypertension can also be a cause, or vital causes may be many, ranging from tumors to acute sinusitis, chronic sinusitis. Intracranial tumors, brain abscesses, pseudotumor cerebri, malignant hypertension, hydrocephalus, tuberculomas, gametas can also give rise to papilledema because of the raised intracranial pressure. And systemic diseases like hypertension, blood dyscrasias like polycythemia vera, leukemias can also cause papilledema. And of course, the endocrine disorders can also cause papilledema. So just a view of the optic nerve so that you can understand the etiology or pathophysiology of disc edema better. If you look at the right, the optic nerve head, the surface nerve fiber layer, then there is a prelaminar region, there's a lamina cribrosa, and the retrolaminar region. So between the prelaminar and the retrolaminar region is where all the pressure fluctuations or changes happen. So that is where the axoplasmic stasis is more bound to occur when we are having papilledema. So there are various theories of mechanism. This is just for your knowledge. It doesn't practically come in use except for high-risk theory, which is the most accepted one now. So there were some non-mechanical theories which are obsolete now, in which they said that because of the inflammation, the toxic elements in the cerebrospinal fluid causes the inflammation of the optic nerve head, and that is why we see papilledema. Then there was Jackson's theory of vasomotor instability, in which he said that because the nerves get upset because of all the changes that are happening, the control of the circulation and nutrition of the optic nerve is affected, and that is why there is a swelling. Mechanical theory says that either there was a venous obstruction in the optic disc region, and that is what causes the swelling. So it is all just venous obstruction. There are some theories which say that the CSF backflow into the optic nerve head, and because of that, the optic nerve head seems swollen. So for papilledema, because of the high CSF pressure, it seeps into the optic nerve head tissue. And the most accepted one is the axoplasmic flow obstruction. So the axoplasmic flow is of two types: anterograde, orthograde, or retrograde. Anterograde has two components, that's the slow component and the fast component. All of this is for knowledge only. And so this is the retrograde flow has the fast component. So what is anterograde and retrograde is the flow is proximodistal, or from the retinal ganglion cells to the lateral geniculate body in anterograde flow. In retrograde, the transport is from the brain to the retina. So what is this terminology and intra-axonal pressure? This is very important in order to understand the whole mechanism of how a papilledema happens to people. So inside the eye, you have the intraocular pressure. In the outer meningeal sheath covering in the subarachnoid space, you have the CSF pressure, and you have the optic nerve tissue pressure in the optic nerve per se, which is passing in between. Okay, so now the pressure in between, that is the pressure gradient between the intraocular pressure and the optic nerve tissue pressure, is what is the intra-axonal pressure. So how do you derive the intra-axonal pressure? It is intraocular pressure minus optic nerve tissue pressure. So when the intra-axonal pressure becomes negative, that is when there is an optic disc swelling. That is when there is a seepage causing optic disc swelling. So when will that happen? Since it is IOP minus ONTP, Either the IOP has to go really low or the ONTP has to go really high. And when does the ONTP go really high? When the CSF pressure is high and it causes a pressure on the optic nerve tissue proper. So these are the conditions in which, like ocular hypertony and anything that causes a raise in CSF pressure is going to cause this. So what is high raise theory? High demonstrated that an increase in the intracranial pressure in the subarachnoid space is transmitted to the perineural space. The increased CSF pressure around the optic nerve head causes a percolation of the CSF into the optic nerve head and increased tissue pressure in the post-laminar region. If you remember the picture that I had shown you before, in the post-laminar region below the lamina cribrosa, this alters the pressure gradient across the lamina cribrosa, and the pressure gradient varies to the prelaminar region. This causes a blockage and stasis of the exoplasmic flow from the retinal ganglion cells to the lateral geniculate body and causes an optic nerve head swelling. So essentially, the optic nerve head swelling here is hydrostatic, passive, and inflammatory. What are the other associated signs? So because of the increased intracranial pressure, there is exoplasmic stasis, optic disc swelling, and subretinal fluid in some cases. The optic nerve sheath distension can cause choroidal folds. Also, in a case of hypotony, you will see choroidal folds. The venous obstruction and edema will cause retinal hemorrhages and nerve fiber layer edemas or exudates. And the optic disc swelling will cause axonal compression, hypoxia, gliosis, and eventually an optic atrophy. So what are the grades of papilledema? Grade 1 to 5 according to Friesen. So I have put down the pictures for you. So in grade 1, there is a grayish C-shaped halo surrounding the disc. To note is that there is a sparing of the temporal disc margin. So it generally starts nasal because of the nerve fiber layer orientation, radial nerve fibers striation disruption. Grade 2, the halo becomes more circumferential, the nasal border becomes elevated, but still there is no major vessel obscuration. The obscuration of at least one vessel leaving the disc, as you can see in grade 3, will cause elevation of all borders. And in grade 4, there will be obscuration of a major vessel on the disc, complete elevation including the cup, and a fully circumferential halo. Grade 5 will show obscuration of all vessels leaving the disc, and all features of grade 4 will also be present. What are the stages of papilledema? First, early papilledema. In early papilledema, generally symptoms are absent. The patient might come to you with mild headache, mild blurring of vision, and he may absolutely not have any symptoms of visual disturbance as well. So disc will be hyperemic. There will be blurred margins, nasal to begin with, swelling of the peripapillary nerve fiber layer, and loss of spontaneous venous pulsation. I would like to remind you that 20% of us normally also don't have spontaneous venous pulsation visible. Then the second stage is the established papilledema, where there is transient loss of vision. This transient loss of vision, generally the patients complain of it after getting up from sleep or when there is a postural change from sitting down to getting up, very similar to hypertension. The disc will show severe hyperemia, moderate elevation, indistinct margins. The cup will be totally obscured. The small vessels will be obscured. There will be venous engorgement, flame-shaped hemorrhages, cotton wool spots, and circumferential retinal folds called as Peyton's lines. Macular star may be present, and the blind spot will be enlarged on perimetry. If it's a long-standing papilledema, it is called as a vintage papilledema. The patient will have variable visual acuity. Visual fields begin to constrict. The disc is markedly elevated, as you can see here. It is called as the champagne cork appearance. Cotton wool spots are absent, hemorrhages are absent, and there are multiple optociliary shunts that are beginning to develop. Atrophic papilledema, that is secondary optic atrophy, will set in. Vision is severely impaired. The disc looks dirty gray, slightly elevated, Very few blood vessel crossings and indistinct margins will be seen. We come to our next topic, which is a part of papilledema, that is idiopathic intracranial hypertension. So idiopathic intracranial hypertension, as the name suggests, it's idiopathic. You don't have any notable cause which you can find, and that is why it is. Previously, it was called as benign intracranial hypertension, but now we know there is nothing benign about this disease. So it is defined by the revised modified Dandy criteria, including the signs and symptoms of raised ICP, no localizing signs except for sixth nerve palsy, no cause for raised intracranial pressure identified on neuroimaging, except for in the neuroimaging of IIH, the only finding that generally is seen is an empty sella. But mind you, empty sella is also seen in a lot of normal patients. So that is the brain MRI. Is CSF opening pressure of greater than 25 centimeter of water. 20 to 25 is still a gray area. It will all depend on the patient's symptoms and whether there is a disc edema to start treatment or just recommend lifestyle changes for them. Normal CSF composition is a must, because again, otherwise it is no more idiopathic if you have a cause. And if there is no alternate explanation for the raised intracranial pressure. So for a CSF opening pressure of 20 to 25 centimeter of water, at least one of the following should be present in order to label it as idiopathic intracranial hypertension. That is pulsatile, synchronous tinnitus, sixth nerve paralysis, Friesen grading 2 papilledema, echocardiography for drusen negative and not echocardiography, echography for drusen negative and no other disc anomalies mimicking disc edema is present. MRV with a lateral sinus collapse or stenosis and a partially empty sella on coronal or sagittal views, and optic nerve sheaths with filled out CSF spaces next to the globe, which causes a flattening of the globe on T2 weighted axial forms. So in 2020, there has been a revised criteria. It is not just a diagnosis of exclusion. It's not that only if you don't have any other symptoms, it can be labeled as an IIH. If there is an isolated increase in intracranial pressure causing headaches and diplopia, when there is an obvious papilledema, when the MRI and MRV rule out any other intracranial diseases and venous sinus thrombosis, when the CSF is absolutely normal and the CSF opening pressure is more than 25 centimeter of water and 28 centimeter in kids, please note that. So that is when you will call it as an IIH. Almost everything is same. Yeah. The etiology, most of the cases of IIH occur in young women who are obese. But this is also not a defining criteria, though it is the most common. And when you have a patient with that profile coming with a papilledema, you should have a high level of suspicion. Patients with higher body mass indexes and recent weight gain are at increased risk. If IIH presents in an individual who is not overweight, it is necessary to rule out associated risk factors such as exposure or withdrawal to certain exogenous substances like drugs, systemic diseases, including Lyme disease, disruption of the cerebral venous flow, we'll come to that later, and certain endocrine or metabolic disorders. So what are the drugs that can cause IIH? Here is a whole list. Systemic associations. Myriad of illnesses are associated with IIH. Some of these are known to increase the viscosity of the CSF. In most, however, the causal link is not very clear. But if the patient is anemic, if there is a chronic respiratory insufficiency, if there is hypertension which is uncontrolled, there is a chronic renal disease, if the patient is a known case of SLE or thrombocytopenic purpura, IIH may be association with it with a normal MRI. Endocrine risk factors. So these endocrine risk factors, most of them will resonate with those diseases which are causing obesity and uncontrolled weight gain. So female sex, reproductive age group, patients who present to you with menstrual irregularities. But in menstrual irregularities, you also have to keep in mind the hormonal profile and the pituitary, obesity, recent weight gain. Endocrine risk factors that meet the minimal criteria but have not been confirmed are adrenal insufficiency, Cushing's disease, parathyroidism, hypothyroidism, excessive thyroxine replacement in children. Pregnancy is also occasionally associated with IIH. It can, it can come in any of the stages of pregnancy. Two things are weight gain is there, tissue mass increases, and hypercoagulability also can cause IIH in pregnancy. Criteria for including a drug or a disease as a cause of IIH, Radhakrishnan et al. Said that at least 2 cases should have been described with a particular condition, and they should have met all the criteria for the diagnosis of IIH that we discussed before. And the main thing to rule out is there is no intracranial dural sinus thrombosis. So that will come in the investigations part. What exactly are we supposed to send in as an investigation for a patient who presents to us with papilledema without any other visible causes that we can rule out on our clinical examination? So we'll come to that later. So the most important point is to rule out the intracranial dural sinus thrombosis. IIH, the prognosis is supposed to be worse in African race, male sex, severe obesity, history of anemia, sleep apnea, hypertension, rapid onset fulminant idiopathic intracranial hypertension, and severe vision loss to begin with. So if you see the patient in a state where the IIH is fulminant or the vision loss is very severe, the fields are severely restricted, then the prognosis is worse. Papilledema and IIH, the visual field compared to other disc edemas, it spares the central vision field till late. So the blind spot enlargement is seen, but there is severe peripheral loss. And so you have to do a wide field, visual field in order to know that. And in cases where it is really bad, you might have to confirm with a smaller field on Humphreys. MRI brain with contrast and an MR venogram is what is the investigation of choice. Rule out any space occupying lesion. And the recent role of OCT in disc edemas, we are not talking about it for a lot, but yeah, the nerve fiber layer and GCC, especially the ganglion cell layer, the cell loss, the ganglion cell loss is correlated with the amount of vision loss, vision recovery that we can expect. So it can be used for follow-up or to detect prognosis, as disc pallor follows the OCT changes of axonal loss and can be useful to differentiate between true and pseudo disc edema. Pediatric papilledema, just a word about it. It's though papilledema is infrequent in infants because the fontanelle is not yet closed, and there is scope for the brain to enlarge. So it is infrequent in infants. In children, most commonly the cause is a neoplasm, craniosynostosis. There have been cases of child abuse, shaken baby syndrome, battered baby syndrome, who have turned up with papilledema, and papilledema can also be because of a subdural hematoma in such cases. Okay, so papilledema in PIH, pregnancy-induced hypertension. So in general, you advise bed rest, control of the blood pressure, control of the edema using diuretics and hypertonic glucose. And for non-responders, when the field starts becoming very narrowed down and when there is nothing else that we can do because it's not difficult to induce surgery in a lady who's pregnant. So in very end stage cases and non-responders, we might need to terminate the pregnancy as well. So what are the mimickers of an idiopathic intracranial hypertension? A typical demographic profile in a male who's known obese, cranial nerve palsies other than sixth nerve. The CSF has an abnormal composition, alteration in the level of consciousness, focal neurological deficits, and a rapid development of papilledema. These are the ones that we should be on a lookout for, that probably it is not idiopathic intracranial hypertension that we are dealing with at all. So you will have to have a strong suspicion for a cerebral venous thrombosis. Treatment of papilledema. Yes, for any case of papilledema, you treat the cause. So when a patient presents to you, first in your clinic, you check the BP, you check for changes of hypertensive retinopathy in the retina. When you go ahead with the neuroimaging, ask for an MRI with MRV. If it's abnormal, that is, if there is a space occupying lesion, you treat the cause. If it is normal, then you can go ahead with the lumbar puncture if there is a strong suspicion. And if the CSF opening pressure is high, then it is IIH. If it's a normal opening pressure and abnormal spinal fluid analysis, then it may be meningitis or any other cause. The treatment wise, if there is no visual loss, generally what we recommend is a low sodium diet, 10% of weight loss, and we can consider acetazolamide after if the papilledema is mild. So though this is the protocol that is given in the books, how we go about is we look at the extent of papilledema, we look at the extent of the visual field loss, and if the papilledema is mild, the symptoms have been quite recent, if there is no like nerve paralysis, and so we ask them to reduce their weight. So generally they are females who are obese. Many of them are not very open to this. They say, oh, no, losing weight, I have been trying all my life, I can't do it. So if you ask a person who weighs an 80 kg and you tell them, no, you have to lose 30 kgs, they are obviously going to say that. So you always start by coaxing your patients to lose maybe 7 to 10% of their body weight, which is pretty possible. And you encourage them that, you come back after 2 or 3 weeks, and then we'll check you again. If you think that there is worsening of the visual field and also, you should call them earlier. If not, we can call them after a month of trying weight loss and low sodium diet. If they are not responding, we start with acetazolamide. Even with the acetazolamide, if there is severe vision loss, then you have to think of surgical options. So what are the surgical options that we have? We'll come back to all the details later. For now, optic nerve sheath fenestration, if the visual complaints are more than the headache, if the headache is more and the other associated symptoms are more, then 24-hour blood pressure monitoring for sleep apnea, and if that is also okay, then we can think of a shunt surgery. Pseudodisc edema. The next topic to consider is pseudodisc edema. We have covered papilledema till now, and it is, are we on time? Oh, it's already 7:45. So yeah, so pseudodisc edema, optic nerve head drusen, medullated nerve fibers. I will be running through it. So in optic disc drusen, you have a hyaline-like substance, trifurcation, blood vessels. So you can see the major blood vessel there has a trifurcation. In myelinated nerve fibers, you will be easily able to spot it if it's a big one like this with a feathery margins and a distal fan shape, which is atypical of proper disc edema. Morning glory syndrome, where there are these spoke-like blood vessels and a hyperemic elevated disc. Tilted disc anomaly, where the vessels are entering nasally, obliquely, the disc is placed obliquely, and there's a lot of chorioretinal atrophy. Optic neuritis. So I'll quickly rush through optic neuritis and the other causes of the disc edema. Optic neuritis, as you know, is the inflammation of the optic nerve causing reduction in visual acuity, function, and or visual field loss. The classification, either it is ophthalmoscopically visible, like papillitis or a neuroretinitis, is you can find it out on ophthalmoscopic examination. Inflammation which attacks the nerve proximal to this region is called as retrobulbar neuritis, which is not ophthalmoscopically visible. So the three types of neuritis are perineuritis, periaxial neuritis, which is seen more commonly in MOG associated, myelin oligodendrocyte associated kind of neuropathy. Axial neuritis, which affects the macular fibers and causes a centrocecal scotoma and temporal pallor of the disc, example in multiple sclerosis, and toxic and nutritional neuropathies. The transverse neuritis, both axial and periaxial neuritis, may progress to involve all the fibers, generally seen in the NMO spectrum, neuromyelitis optica spectrum. So the etiology, I'll just quickly rush through it. It may be idiopathic, demyelinating disorders like multiple sclerosis, ADEM, neuromyelitis optica, Devick's disease, diffuse periaxial encephalitis, infections like endophthalmitis, orbital cellulitis, sinusitis, and contagious spread from meninges, brain, and base of skull are the local infections that are involved. And systemic, there may be a myriad of bacterial, viral, and protozoal fungal infections that can cause optic neuritis. I would say that I have seen maximum cases of viral infections which have presented with optic neuritis. Immune-mediated disorders, locally, uveitis and sympathetic ophthalmitis, and systemic diseases like sarcoidosis, vaginous granulomatosis. So the most common type of optic neuritis in children is, any guesses? Papillitis. And the most common cause of optic neuritis, in children is post-viral. Okay, this is an MCQ which you can keep in mind. And yeah, so the clinical features, more common in women 20 to 40 years. Visual loss is usually unilateral, but in children it can present with a bilateral presentation. The pain increases on eye movement, elevation, and adduction because the involvement of the superior rectus and the medial rectus, which share the same sheath with the optic nerve. If you remember the diagram of the superior orbital fissure that we draw, so the compartment that encases the optic nerve, the superior rectus and the medial rectus share the same sheath. Uthoff's phenomena, that is, there is worsening of symptoms on exercise or rise in temperature seen in multiple sclerosis. Fritz phenomena, that is, there is an altered perception of a moving object. There is loss of color vision, typical red desaturation, reduced perception of light intensity, RAPD, and visual fields central, causing a central or centrocecal scotoma. So one thing that I would like to stress on here is whenever a patient comes to you for a normal examination and you see that there is a change in the retina, the optic nerve, so the main things that you should immediately go on for, which will rule out a lot of causes of optic nerve inflammation per se, is the color vision. The pupillary examination. The pupillary examination with the swinging flashlight test. The only place where you might find it difficult if there is bilateral involvement or if there is an atrophy of one eye optic disc. You might have a fixed dilated pupil, so there is like nothing to compare it with because it's a relative afferent pupillary defect. So the red desaturation, you can just simply take any red colored object, a red pen, and ask the patient to close one eye. In fact, there are some apps online on Play Store as well, in which you can check the desaturation levels. Like there are spots which are in red, orange, pink, brown, all shades of red, and then you can ask the patient to close one eye and tell what color he's being able to match with the affected eye and with the unaffected eye, and you can find out if there is a desaturation. So fundus findings and retrobulbar neuritis will be normal. There might be vitreous opacities. Papillitis will show disc hyperemia, peripapillary flame-shaped hemorrhages. Neuroretinitis will show a disc hyperemia with a macular star. So this is the case of papillitis, and this is the case of neuroretinitis. Please note that the rest of the vasculature is normal in this case of neuroretinitis, and that's why we are not labeling it to any ischemic etiology. So what are the atypical features that you need to think of whether you're dealing with an atypical optic neuritis when there is an absence of pain, when the patient presents to you with very severe vision loss, maybe no PL, when there is a marked optic disc swelling with retinal exudates and peripapillary hemorrhages, when even after 3 weeks of treatment, that is after the IV steroids have gone in, after the oral corticosteroids have been taken, there is lack of recovery, and when there is bilateral involvement, you have to suspect that you may be dealing with an atypical case. So this is a case of neuroretinitis, which has no other infective etiology, Leber-scale neuroretinitis. Do note that neuroretinitis is a totally different entity. When you are treating optic neuritis, you go more on the lines of the demyelinating diseases, and then look for the infectious ones. But in neuroretinitis, there is no risk of multiple sclerosis. Mostly it is due to the diseases like cat scratch, Lyme disease in an immunocompromised patient. Look for systemic causes. It presents like optic neuritis, but the response to steroids is very good. So once you find out the cause, you treat the cause and give steroids along with. Pediatric optic neuritis, like I said, is usually bilateral. The swelling is more common. Treatment needs to be more aggressive because they are generally immune mediated, post-viral, post-infectious, and there is a good chance of ADEM being set in those patients. So you treat aggressively so that there are no permanent issues, neurological issues. The prognosis is generally good, as with a lot of diseases involving pediatric age group, and idiopathic demyelination may happen, and 10 to 50% may eventually go on to develop multiple sclerosis. So you have to see the first episode. After the first episode, you have to keep the patient on monitoring or follow-up in order to see whether he's developing an MS. Investigations, visual fields, that is the perimetry will show a central or centrocecal scotoma. The VEP will be prolonged, the latency will be prolonged. P100 will be prolonged. The complete blood count should be done in order to check for the ESR levels, the CBC, in order to see if there is an infective etiology and allergic etiology that can be pointed at. RPR, then fluorescent troponemal antibody test for syphilis, anti-nuclear antibody test. MOG and NMO antibody titers. So I will give you a few pointers on neuromyelitis optica and MOG spectrum of diseases, how it will be different from a typical multiple sclerosis, optic neuritis. So the MRI brain and orbit should be obtained with contrast, gadolinium enhancement, generally fat suppressed images. For a multiple sclerosis, what you will see is if the patient is affected, he will have periventricular plaques around the ventricles. And if it's a MOG type, perineuritis might be the more common or more prominent thing that you will notice. And in the NMO spectrum, it might involve the longer segments. So if you feel after taking the MRI with contrast and treating the patient with IV steroids, if you see that the recovery is not as much, or the patient is also complaining of some limb weakness and some other associated abnormalities, it is a good idea to get the spine MRI with contrast as well, to look for long segments that are involved in a case of neuromyelitis optica. Yeah, tuberculosis, which is common in our country, X-ray chest, MAN2, sputum, and sarcoidosis. You should always look for, in the age group of like above 40, always look for blood sugar differentiate whether it's optic neuritis versus an ischemic optic neuropathy. So one of the other and other cranial nerve inflammations is chronic sinusitis. there is a theory that says that because of the chronic sinusitis and because the sinuses are so closely placed to near the eye and where our nerves are exiting, especially the sphenoid sinus, there are chances that the long-term sinusitis, the inflammatory cytokines and all can cause transient inflammation and cause some kind of nerve edemas or nerve inflammation leading to movement disorders as well. So this is a table showing the differences between neuromyelitis optica versus multiple sclerosis. So the severity of attack is more in Devick's disease, whereas multiple sclerosis is generally mild. And the CSF will show pleocytosis during NMO attacks, and it'll rarely show more than 25 white cells in a case of MS. Oligoclonal bands are what need to be looked at when you are doing a CSF tap. They're usually present in multiple sclerosis, and NMO generally causes a very permanent kind of a disability as compared to MS.
Excuse me, ma'am. How many more slides we have to go?
Okay, I'll have to. Yeah, so I think there are almost 30 more slides to go. So what
No.
I'll do is I'll just finish off optic neuritis.
Otherwise,
Yeah,
what we can do, ma'am, is since it's a very important topic, also optic neuritis.
yeah.
I think we will not hurry up with the optic neuritis, and we will have a separate class on the optic neuritis and the AION and AION whatever is pending.
Yes, sure, sure, sure. That is a good idea. The only thing that is remaining is the answers to what we had discussed before. So I
Then
think I'll just
yeah, we'll close
I'll just
the
give
answer,
away the answers and yeah,
and
I
then we
think that
will discuss if there are any questions.
yes, 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 definitely.
So this is a question one, and I will launch answers. What people had answer for the same. Ma'am, you can continue sharing the screen.
Yeah, the screen is being shared. Can't see it?
No, I mean the question. If
Yeah, can you see it now? Yeah.
so, question one, and the most people had answered it as a FFA. Ma'am, can you tell us the right answer, please?
Okay. So first, let me discuss the case with you. A 32-year-old obese female presented to the OPD with complaints of transient obscuration of vision in the morning. So it was associated with headache. The vision is 6/6. Please note that. Color vision is normal. Confrontation is normal. Anterior segment is within normal limits. So you have answered that is an FFA, but the actual answer is do the visual fields first. You do the visual fields first because even though the patient see an enlargement of blind spot, the patient will not complain of any visual field effect. Okay, so the first thing you do is visual fields. Okay, fundus fluorescein angiography again becomes invasive. So once you have the visual fields, then you can decide on whether or not to do the MRI, MRV, any other investigation. The first thing you do is visual fields, and then you can, according to what you see, you can think of FFA. Okay, so this is what the patient had. So she had an enlargement of the blind spot, and she was a typical case of IIH, and we treated her with acetazolamide. And so this is how the edema resolved after 11 months. We generally give acetazolamide for long term if there is no control. In the literature, it's written that you can give up to 4 grams. in our country, because we have massive side effects of the acetazolamide. There is really bad tingling and numbness, and all the patients complain of it. So generally, the dose that we start with, depending on how bad the papilledema is and how bad the other symptoms are, 250 milligram, half a tablet morning, half a tablet evening, or you can start with 250 once in the morning, once in the evening, or bin in 4 divided doses as well. And then looking at the disc edema resolution and the fields, you can probably monitor them and increase or decrease the dose. But I have rarely gone up to 4 milligram. 2 milligram is the maximum that we have gone to, unless you have to start bang on 2 milligram as soon as you see the patient. The second case was a 50-year-old male presenting with painless gradual blurring of vision. So what is the answer?
So this is what people have answered as MRI angiography as the most commonly answered option.
Answered option. Okay. Okay. I'm glad it's not the wife. Okay. So, so in this case, what we did was sleep studies, which came out to be positive for sleep apnea. See, the thing was the patient was having papilledema. The CSF is not showing, the CSF is not showing on LP. There is no raise in intracranial pressure. Normal CSF. So what is causing the papilledema? Okay. So yeah, an MRI brain with MRV was normal. So then why would you do another MR angiography? Okay, so this wife complaining of whooshing sound is also something which is seen because of, they generally say, because of the transverse sinus narrowing. That can be the reason why the turbulence of the flow is causing the whooshing sound. So in this patient, the sleep studies were positive. An intracranial bolt measured as intracranial pressure to be 40 centimeter of water in sleep. So when the patient was sleeping, because of the sleep apnea and the consequent ischemia and the consequent difference in the pressures between the ICP, intracranial pressure, and the intra-axonal pressure, there was stasis and causing disc edema. So the third case was of the 12-year-old boy. So what have people answered to this?
Answer for the third question is this. Optic nerve glioma is most commonly answered option, followed by intracranial tumor.
Okay. So see, he looked abnormally tall for his age with a rather prominent jaw. That was the clue to tell you that he probably has acromegaly, and it may be a pituitary tumor that is staring at your face. So this is the picture. This is the wide field and the post-surgery clearing of the fields. There is the tumor staring. It was a Rathke cyst kind of a tumor, a congenital cyst kind of a tumor. So transpinal excision was done, and you can see how well the vision cleared. The symptoms became lesser. Okay, so I think we have only 3 cases discussed, right?
Yes, ma'am.
Okay, so the magic mantra of getting a diagnosis right: same old, what everybody tells you: proper history, detailed examination, relevant examination, prompt reference, and most importantly, don't stop till you get to the root of the problem. At times you look at patients with a particular condition, and you feel that you go in a particular path, thinking, like in the past 2 cases that I showed you, your thinking process was not wrong. But if you look at the patient as a whole, you take the entire history and you think about the vision loss, the quantity of vision loss versus what you're seeing ophthalmoscopically, and versus the investigation reports that you have, you can easily derive at a good conclusion, at a proper diagnosis. Do refer where necessary. Like even with my IIH cases, I still prefer to send the patient across to a neurologist before starting the systemic medication, acetazolamide. So, most importantly, don't stop and keep keep going to the root of it. Keep investigating till you find the problem. So that would be it. I would end my lecture for today. Thank you very much for a patient hearing, and I think we can take a few questions. Can we?
Yes, yes, ma'am. Thank you for that lecture. It was very informative, though we could not finish it. So we will, of course, continue in the next. We have one question here from Dr. Meghna. The last case that we discussed of acromegaly and the tumor. So the question is why it cannot be optic nerve glioma. There is no MRI report been mentioned.
Okay. So yeah, any case that you see can have, it can have something to do with when you do the MRI, it might come out to be totally different. One thing I want you to note here is the patient did not really have a massive vision loss, and the color vision seemed to be normal. The only thing that came out positive was the visual fields showing a bitemporal hemianopia. Okay, so that would not be the case in an optic nerve glioma. The patient will have visual problems. Yeah,
And proptosis as well.
yeah, proptosis as well. That is in later stages. If it's a smaller kind of a glioma, vision will definitely be affected. Yeah.
Then I have a one question, ma'am. Like
Yes.
for IH, you said you can continue acetazolamide for longer duration, but
Yes.
as you know, many times patients are not very much compliant with such kind of treatment. So the surgery or the shunt, does it work, and do you advise it? And if you advise, then in what stage do you advise?
Okay. So this is a very relevant question because we have patients who have been years on acetazolamide. So what you do is you have to check with their symptoms. You have to give them the dose which is enough, just enough to get their pressures down, to get their symptoms down, to get their fields better, and which is also like we normally do case all substitution, ask them to have food which is rich in potassium, like that is the way. And what we need to stress here is if the patient is obese, just getting down the weight will automatically reduce their vision problems and their symptomatic problems like headaches and all of that. So automatically we can reduce the dose of the acetazolamide. What I do generally is call them after say 4 weeks or 8 weeks, depending on how bad the papilledema is, and then you try reducing the dose after say 2 months of treatment when you see some improvement in the papilledema. And if the patient gives you a call and tells you, no, I'm still having the problems have recurred, or I feel that my vision is going bad, then you wait for another 2 months and then you start reducing. And if you feel in that meanwhile that the perimetry or the optic disc edema per se is becoming worse, then you might have to increase the dose as well. But going in for an optic nerve sheath fenestration or a shunt procedure is very drastic unless you have like really bad pressures and the fields are worsening at a very fast pace. I reserve it for those kind of cases where there is a good established kind of a papilledema and the visual field is really bad, like and those cases in which if the systemic symptoms are higher, go in for a shunt. Like if the headache is very bad and if there are any other localizing symptoms, neurological symptoms, you go in for the shunt. Otherwise, it is surprising, but people also go in for bariatric surgery just in order to reduce the weight. I wouldn't recommend that, but if a patient does ask you, कि मैम मेरे से weight तो lose नहीं होगा, probably I'll go ahead with surgery. You can consult with the surgeon and you can give a go to that as well, because the weight loss is the primary key.
And how do you keep them on follow up? Like the fields to be repeated every 3 months, 6 months, or is it a earlier follow up than that?
Okay. So, depending on at what stage you have seen the patient, if it's a bad case, then you do the fields more often. And also, after you start with acetazolamide, your first field should be done within the 4 to 6 week, so that you know whether the acetazolamide per se is working, whether you need to add more or you can make it lesser. The patient then, if they are symptomatic, they will tell you if there is a reduction in their symptoms. You can correlate it with the because ophthalmoscopic findings will also not go off immediately. So it will take some time. So you have to give it around 4 to 6 weeks for it to settle and for us to see a clear improvement in the stage of the papilledema as well.
There are not many questions today. So I think, ma'am, we will.
Was I very good or was I like,
No. You are
did
very
it
good.
all go like
Dr. Susha,
tangentially? Yeah, yes.
Dr. Susha, this is Dr. Swapnesh. I am the secretary of BOA,
Hi.
and it was a wonderful lecture. In fact, you took away the thunder from my talk. My by saying that some patients undergo bariatric, I thought I was going to add that point at the end because I have one patient.
Oh,
I have one patient, actually my neighbor, who had
oh,
IIH, and I was following her up with in consultation with a neurologist, and
yeah.
she was on 250 milligrams of acetazolamide 4 times a day, and
Uh,
only after that she could get her symptoms back. But it was kept on recurring once I reduced the dose below 500. So
yes.
finally, and she's from a very healthy and a wealthy family, so it was impossible for her to diet, and finally she underwent bariatric surgery, but only after 3 months of that too, then her symptoms kind of relieved.
Relieved.
But
Yeah.
unfortunately, the effect lasted only for 2 years, and she was back to the
Her old
beginning
self.
of the, yes. So she was back to Dimox, but now she's maintained only on 250 milligrams, and her symptoms are not so much.
Yes, yes.
So
Yes.
that was a first-hand experience of a bariatric surgery, uh, doing
Yeah,
well for a few years and then coming back.
it seems extreme, but trust me, it's lesser in India. You go outside, it's a routine, it's a norm. Insurance covers it.
Yeah, true, very true. And also, I would just add quickly one case which I scratch my heads for. About 20-year-old young female who
Okay.
presented with flashes and photophobia, maybe drop in vision just by one line, or she was kind of apprehensive because of the photophobia, and there was just a buried drusen at one of the optic nerve edges, but it was
Mm-hmm.
not very classical, not picked up on
Okay.
B scan. I myself did the B scan, and obviously there was panic because she was a young girl giving exams. Did
Yeah.
MRI. MRI came out to be normal. She had some symptoms about allergic lid swelling, so got a sinus reference also from a ENT specialist.
Yeah.
Query sinusitis, treated, did well, again came back with the same symptoms. Finally, because her vision was always 6/6, her color vision was always normal. I had hard to write on the paper that evaluate this in terms of a pseudo papilledema, because never ever in the follow up her vision was always 6/6, 6/9, and
Okay. Uh-huh.
typically in a case of even papillitis or optic neuritis, the vision will fall down. Am I
Will-
right or wrong?
Yes, yes, yes. If it's a papillitis, it will fall down.
It will fall down.
Yes.
So and the picture still looked the same. And finally, now she's been treated only for the allergy by the ENT
So
specialist.
her symptoms were only the allergy. She didn't complain of any vision issues.
She had, but it was
She
very
had
vague.
vague.
Just because I saw a very unclear disc margin in one of the eyes, obviously the panic set in because she also associated the symptoms with photopsias and blurring. So obviously, when the
Yeah,
allergic,
yeah,
so you tend to take that sign very seriously in a young
yeah.
patient.
Yes,
So thank you very much, and
yes.
we look forward for your second lecture.
Yes, I look forward to it too. I hope we can arrange it soon since I
Sure,
have the
sure,
slides ready.
sure.
So,
Sumit,
yeah.
thank you very much.
You, sir.
And sorry for joining late. As you know, the OPD has picked up, so closing times are now extending beyond 7:30.
No problem, sir.
That's good news.
We will take some of the lectures for you.
Thank you. See you all. Have a good evening.
Thank you very much for the opportunity, Dr. Swapnesh, and
Yeah.
thank you, Sumit.
Yes.
So, bye bye for now.